Hello and welcome to this lecture. Today we are going to discuss another topic which is cirrhosis, and I'm presenting the case of a 59 years old patient is divorced and unemployed. He was admitted to an acute medical ward at the hospital presenting with the general malaise, a gross distended abdomen, swollen ankle and feet, and jointings. It is also noted that he smelt of alcohol and was showing sign of alcohol withdrawal. The patient also had reported feeling very weak and fatigued and is experiencing anorexia and enlarged vein. To note, his bilirubin level are extremely high, which is approximately 3 milligram per deciliter, which is too high. That explain why he has slight jaundice in the skin. So the learning objective of this topic is what is cirrhosis and is there any relationship between alcohol and cirrhosis? What would be the general pathogenesis in cirrhosis and discuss the clinical features of cirrhosis. So it is defined as a diffuse process characterized by fibrosis and the conversion of normal liver architecture into structurally abnormal nodules, and the major cause include chronic viral infection, alcoholic or non-alcoholic steatohepatitis, autoimmune disease affecting hepatocytes, iron overload. So there are a number of causes. Alcohol is one of the reason. Hepatitis A, B, C, or viral infection, or autoimmune disease that are affecting hepatocytes, and excess iron is also responsible. So what happened when we talk about pathogenesis? There will be death of hepatocytes, and we know that hepatocytes are the basic unit of the liver. And what happened? There will be extracellular matrix deposition, which can be explained in terms of fibrosis. As I mentioned in the definition, fibrosis will be there. So the extracellular matrix deposition explained in terms of fibrosis. Then vascular reorganization also occur. So this is the liver. We have to understand liver contain liver lobules, and each liver lobule consists of a different items such as hepatocytes. We have central vein that feed the hepatic vein. Then we have sinusoids. Then we have bile duct. We have branches of portal vein, and then branches of arteries. So we have arteries, vein, bile ducts, hepatocytes, central vein that is connected with all portal vein and branch arteries. Then we have sinusoids. So this is the structure of, or you can say that anatomy of the liver lobule. If you take a look on the left and right side, on the left side we are presenting the normal liver. On the right side we have liver fibrosis. So what is the main changes? Number one, the Kupffer cell we are there, but in liver fibrosis there will be activation of Kupffer cells. The main thing, the other thing is that in the normal liver we have fenestrated sinusoids. It means the space between endothelial cells, which actually in liver fibrosis there will be loss of fenestration. Then the other thing that is actually missing in the liver fibrosis is the loss of microvilli. Then the other things that we will found that there will be dense extracellular matrix that I already discussed. Then we have the activated myofibroblast in the liver cells in the liver fibrosis. What will be the clinical features? The clinical features consist of anorexia, weight loss, weakness, and the fatal cirrhosis involved one of the following mechanism, either because of the progressive liver failure, because if someone is drinking more than 30 years, a chronic drinker, so it could be causing death. Then a complication related to portal hypertension. Then the development of hepatocellular carcinoma, as 10 to 20% drinkers can become carcinoma in the hepatocytes in the liver. Then we are going to discuss portal hypertension. We are going to discuss two topics in this lecture. One is cirrhosis and the second one is portal hypertension. In portal hypertension, I am presenting the case of a female, 30 years age, had been diagnosed with pulmonary tuberculosis 3 years earlier and treated with triple regimen of isoniazid, rifampicin, and ethambutol for 1 year. As isoniazid, rifampicin, and ethambutol are the drugs that used in combination for the treatment of tuberculosis. And on regular follow-up, no reoccurrence of the pulmonary TB was found. This time she was admitted with a chief complaint of hematemesis, melena for 3 days. The laboratory test showed normal liver and kidney functions. Hepatitis B is negative. HIV, hepatitis C virus is negative. No TB lesions on chest CT scan. Abnormal ultrasound indicate a portal venous stenosis along with tortuous expansion of the vein in front of pancreas, and abdominal CT scan showed splenomegaly, portal venous stenosis, esophageal varices, and lesions in the left hepatic lobe. So this is the detailed information of one patient, and we mentioned that the patient has recovered from TB. He has no hepatitis, no immunodeficiency disease, but they found that laboratory test is showing a normal liver, as they do not find any abnormality. But when they perform abdominal CT scan in the last section, they find out splenomegaly, portal vein stenosis, esophageal varices, and lesions on the left hepatic lobe. So that's from this last paragraph we able to diagnose with the portal hypertension. And we mentioned that after discussing among the case diagnosed as upper gastrointestinal hemorrhage, portal hypertension, splenomegaly, esophageal varices, and maybe cancer could be possible, which has not been ruled out. So this paragraph is giving you a detailed information. What are the learning objectives? They are very short. One is that why portal hypertension is considered as clinical syndrome, because this is a big clinical syndrome related to the portal hypertension, and what is the pathogenesis. And when we discuss the portal hypertension, we know that it is a clinical syndrome characterized by the multiple diseases with splenomegaly, which is enlargement of the spleen, then ascites, then gastrointestinal varices, and encephalopathy. So these are the three main things: splenomegaly, encephalopathy, and gastrointestinal varices. These are the things that have been found, where we found that splenomegaly in terms of the spleen enlargement. Then you can see that esophageal varices. In this case, what is esophageal varices? It can be explained in terms of enlarged veins. So the veins in the esophagus will be enlarged. And then we also have ascites, which define abnormal fluid buildup in the abdomen. As you can see that the swollen abdomen. Then we also found that encephalopathies. What is encephalopathy? We can say that it is defined as the chronic inflammation, or you can say that the degeneration of the brain. And the pathogenesis is actually its increased movement of intravascular fluid into the extravascular spaces, and caused because of the sinusoidal hypertension and hypoalbuminemia. That is why the abdominal cavity becomes swollen, because fluid accumulate, which is explained in terms of ascites. Then leakage of fluid from hepatic interstitium into the peritoneal cavities. So this is a picture to explain this section, the greater sac of the peritoneal cavity, and I just put this picture to explain the anatomical structure. So you can see that this area, the sac, the fluid will be built up over there, and that is where the abdomen becomes swollen, enlarged, because the fluid will accumulate. And if you take a look of cross sectional, this is the cross section of the body. If you take a look of the cross section of the body, we found that this is a liver, and we know that hepatic arteries are present with there, and we know that if the fluid will be built up over there because of the vascular leakage, then the fluid will accumulate in the peritoneal cavity and result in enlargement of the abdomen. So we mentioned the leakage of the fluid in the hepatic interstitium into the peritoneal cavity. This is the picture that we have to understand that the liver consists of central vein and then portal canals. So this is the structure. Again, another picture of the liver lobule. So this is the central vein, and then around them we have portal canals, and we can explain them of portal veins and hepatic arteries, and also have the bile duct. So that's actually the diagram of the classic liver lobule. And then you have to see that we also have hepatic sinusoids, and we have perisinusoidal space. And what is perisinusoidal space? Perisinusoidal space is the space between the hepatic sinusoids. So this is the hepatic sinusoids, and the space between them is space of disc or perisinusoidal space. This is another picture to explain the space of disc. And if you take a look, I will just annotate to explain this thing. This is space of disc, and you can see the space actually is around hepatocytes and sinusoid. If you take a look, that this is sinusoids. The central part is explained as lumen, sinusoidal lumen. On the left side and right side, both sides of the sinusoidal lumen, we have hepatocytes. So the space between them is actually the space of disc. And if you take a look of this section, cross section, this structure that is I am highlighting is known as sinusoids, and these are the hepatocytes. The red one is sinusoids, and actually the space between the hepatocytes and the sinusoids is explained as space of disc. So again, this is the central part, sinusoids. These are the hepatocytes, and the space between the sinusoid and hepatocyte is explained as space of disc. So thank you so much for today's lecture. Hope to see you again.